and I'm going to talk fast because I have lots of ground to cover. So don't try to, just sit back and relax and let the information come to you. Get a feeling for it. I want you to get out of this room with a feeling that, what you are dealing with, not with a specific diagnosis and the treatment and so on. So it's a big deal. We are spending lots of money on the spine. And the numbers of the spine problem are increasing. It's getting more expensive. And almost everybody knows somebody in your family who has a spine problem. Who doesn't know anybody in his friends or family area that has a spine problem? Raise your hand if you know of nobody in your family or friend that has a spine problem. I don't see any hands up. So we'll come back to that. This is my disclosure. Look at this person. You remember we talked about pain is emotional. Pain is actually only makes sense when we understand the emotional response to that. We in the industrialized country, we are very pain sensitive. We are comparing to people like in Africa where they walk half a day with a broken leg and just go about their days. We are very pain sensitive, but there is an advantage to that. Look at the life expectancy of us comparing to other countries where they are less pain sensitive. So by us being so pain sensitive and avoiding damage, we live longer. And you may argue, is it a good thing or not? I think it is. So when somebody comes and they complain about the pain and we say, can you not just live with that? That is the advantage of us being pain sensitive. We live longer, we reduce our damage. The rest of the world is catching up to us. Look at that. The life expectancy in most of other countries was far below us. They're catching up with that. Guess what else they're catching up with? Spine problem. Spine is one of the biggest reasons for disability, for pain. From 1990s to 2015, we went from, United States went from 3 to 2. The rest of the world wasn't even there. Now it's now number 4. They're catching up with us. And these two last slides, they are related. They are not independent slides. We have put a system in place that, I'm very happy for that presentation, for that case, that we went through that and when to do surgery, when not to do the surgery. I think this presentation is not going to cover that because that is like a whole semester of information about when to do the surgery, when not to do the surgery. We give this talk, we give CMEs for this. It's all online. If you're interested, come and join us. But we have put a significant system in place that we put the patient through, take our emotional, like the same pain seeker comes and we are burned by that person multiple times. We put them again through the same protocol to do the right thing for that situation. And in our place, we are able to, for 100 people that we see in our system, to send only 5% to the surgery. So 100 clinic visits, 5 surgeries. By being able to combine multidisciplinary, many people that can help the patient to get the proper care. Now, let's talk about the case that we just saw. That patient came obviously with a injury, and by the way, thank you, that was a good case because I can use it now to give you an example. Has a L4-5 lateral or far lateral disc herniation, and has the radiculopathy going down the leg. And in this case, we would have gone to, in this protocol, we would have gone to the basics. What is the differential diagnosis? Sacroiliac joint, hip, and obviously herniated disc. In most of other protocols, herniated disc, MRI, would have completely ruled out the other stuff and they would have concentrated only on the herniated disc. But with this protocol, even though it's less likely, we put all 3 on the table and investigate them systematically. And this is the advantage of that you don't miss things. So if you're interested, just join us, we'll explain this to you. Now, this is what I tell my patient. A disc is like a tire of a car. And the way you can have a flat tire, you can have a herniated disc that was the case we just discussed, right? this is not, the spinal problems are not uncommon. As a matter of fact, if you are 50, I've never had a spine problem, you're among 31% of the population. By your 60s, you are among 5 to 6% of the population. And if you are 70 years old and have never had a spine problem, you're a minority, you're a rarity. And many discs don't need a surgery. Many tires, you can just patch them. But which of you thinks you can patch this tire? Most of the time, that is where I come in. So, and our goal with you, with your help, is make sure this doesn't become this. And you can help. We will talk about that, how you can help by bringing balance to people's life. Now, at this point, I'd like to invite Lindsay to come here and give you what non-surgical means are that we can do. This is obviously a small expert presentation about physical therapy side. There are other modalities that we can provide, but please, Lindsay, if you don't mind to come here and, I'm going to give this to you now. Thank you.
All right, everybody hear me okay? Good. All right, so there's 4 of us PTs talking today. I'm just gonna briefly talk about what you'll see in a PT evaluation, go over a couple gold standard outcome measures, and then how we choose interventions we do with patients based on clinical practice guidelines sent forth by the American Physical Therapy Association. So when we have a patient come to see us, we know based off today's topic that they're going to be coming in for low back pain. We're going to dive into those questions to try to figure out the source of that low back pain. So when they come in, we're going to ask them exactly where they're feeling the pain. Is it in their back? Is it going down their leg, into their hip? Is there numbness and weakness involved with it? When does the pain come on? Is there certain motions they do? Is it tied to a certain activity? We're going to ask them and review their day-to-day routine with them. They might not know what's causing their pain, so if we know what they're doing for work or what they're doing throughout the day, we can try to pinpoint certain activities that may be causing their pain. We also have them always fill an outcome measure, and we'll dive a little bit into those 2 that I mentioned I discussed here in a minute. But outcome measures are becoming more and more important to utilize because insurance companies are often using them for either approval or denial of more services. We've been seeing more and more of that in our practice, that if therapy maybe is not working and there's not an outcome measure that was done at initial to get their baseline, and then at a 30-day interval or whenever we're needed to fill it out again, that insurance isn't allowing that next step to happen. They're wanting more therapy and wanting that outcome measure data for themselves. After we get their subjective history, we then go into our formal assessment. So when the patient comes to us, we're looking at posture, alignment, myotomes, dermatomes, doing special tests, looking at their overall stability and potential tension tests that may be positive for them. And with all the subjective and objective history, that we're then going to make our assessment of what we think is causing their low back pain, and then set forth with our plan. So 2 outcome measures that the APTA recommends to use is either the Rowland-Morris Disability Questionnaire or the Oswestry Disability Index, better known as the ODI. So the Rowland-Morris is a 24-statement questionnaire, and for this, what the patient will do is simply just put a check mark by the statement if it describes them and leave it blank if it does not. The questionnaire has high internal consistency at 0.93 and doesn't need too many points of change to demonstrate a significant change. Some studies are showing that just a minor 2 to 3 point change indicates significant change, where some are more up to the 5 point is what they're saying is needed for that significant change benchmark. The ODI has 10 different headers with 5 blanket statements underneath them, and what the patient will do is just choose which best describes their pain or disability they're experiencing based on the header. For this one, points are doubled, so it ranges up to 50 points, but then when we look at the disability percentage, we are just dividing over 100. So 15 points on this one indicates significant change. The one thing with the ODI that we need to be aware of is that there's many different versions out there. And we noticed this when we were doing, looking to get our spine accreditation at Riverview, that we need to make sure that we're using one that has the research back to it. So I worked with with the librarians at the APTA and realized that when we are using these, we need to be using the original Oswestry or version 2.1. So you're going to see some data will have other outcome measures that are saying they're the Oswestry, but they're really not. Those people took the original, tweaked it how they wanted, but never got permission from the author. So most studies that are being utilized, it's the original ODI or 2.1. So just make sure that you're using something that has the research back to it. So in your practice, how do you determine which one is best for you? APTA doesn't really set forth one that is superior to the other. They both have great power in discriminating change, have good internal consistency. They come in multiple languages and they can be used in different settings. So the one benefit to the Roland Morris that they came up with is if you're having to do a lot of follow-up over the phone, if the patient's not coming back to you for some reason, the Roland Morris would be the easiest one because it'd simply be reading of the statement and they just tell you yes or no. Whereas with the Oswestry, you're reading in the header 5 long sentences and then having the patient try to remember, oh, I think it was answer number 2. So in order to have good response from the patient and most accurate, the Roland Morris would be more beneficial if you're having to reach out to patients, not in person. So how do we choose what is the best way, what interventions work best for the patient? We're going to review the clinical practice guidelines, like I said, set forth by the American Physical Therapy Association. So the intervention is going to depend on the pathology present and also what stage their low back pain is in. The first type of patient we're going to look at is people coming in with low back pain with mobility deficits. So these are going to be people with a lumbosacral segmental dysfunction or somatic dysfunction. They're going to have complaints of typically pain on one side of the body, usually tied to a certain recent awkward motion or position they've been in. They're, like the title says, going to have restricted lumbar range of motion and also probably have restrictions in their different segments throughout their spine that have been affected. Acute stages, you're going to see a definite decrease in lumbar range of motion, but when you're reaching the subacute, they might be able to get to their full range, but they're going to have pain at those end range sites. So what the systematic reviews stated that they included in this study was that manual therapy, both thrust and non-thrust, could be utilized to help these patients. Therapeutic exercises to maintain spinal and hip mobility, and then moving on after gaining some range of motion and mobility for that patient, moving on to the strengthening, coordination, endurance exercises. So anytime we're talking about strengthening for the spine, we're really honing into transverse abdominis and multifidus to really get the patient's own internal core strengthened to give them that stability. Also educating the patient to return to an active lifestyle. If they're sitting at home and not moving, that pain's just going to be more and more elevated. They're going to get more restrictions following them. The next grouping they have is acute low back pain with referred lower extremity pain. So these are the patients that may be coming in with like flat back syndrome or disc displacement. They're most likely going to have increased pain with flexion-based activities. So what we want to do for these patients then is going to be extension. Anything, whether it's therapeutic exercise, manual therapy that will promote that centralization through extension-based exercise is what's going to work best for them. Traction does have a little bit of research backing it for this type of patient. Educating them on positions that are going to help centralize their symptoms. So again, anything extension-based. This is where that subjective history comes into play when you're reviewing their day-to-day activities. trying to educate them on, oh, you're, at your desk for 4 hours, you need to make sure you're getting up every so often to get that extension. Or doing McKenzie type things, a repeated extension to help centralize those symptoms. Once we are getting the pain to that centralized location, then we're going to treat them as a coordination impairment patient. So these type of patients are going to be the ones coming in with different spinal instabilities. So the thing we need to do for them is really promote their internal stability through core strengthening, like we just talked about. But sometimes patients are so weak they might benefit from a short-term external bracing. It's important to tell a patient not to wear the brace consistently, because then they're going to get even weaker in their own internal brace system. Educating them on neutral spine throughout their day-to-day routine. So this would be through transverse abdominis activation and going over many different their body mechanics throughout their workday and at home. And then focusing on manual therapy and exercises that are going to help them with mobility deficits once they're reaching that more subacute phase. But the biggest piece for these guys is the strengthening. Next category would be low back pain with radiating pain. So patients coming in with sciatica. Acutely, they're going to complain about, yes, pain down their leg, maybe numbness, tingling as well. It's not until that subacute or chronic stages that typically they're going to have strength deficits or reflex deficits present when you're assessing them. So again, for this type of patient, traction does have some research supporting its intervention. Otherwise, we want to just get things moving around the affected nerve root through mobilizing structures right next to it, doing some nerve gliding, and then again, educating them on positions that may be causing nerve irritation or could decrease it. So just for example, in these couple pictures here, with her flexion, that would obviously be putting more stress on her disc if she was having a posterior displacement and irritating the nerve. So just educating them the simple changes they can make for this, if this PT stretching a patient would just be elevating the table to allow her to be in more extension. And last category, somebody coming in with chronic generalized pain. These are going to be typically the patients if there's something more central nervous system going on or with a pain disorder. So with these patients, we really want to educate them on the pain cycle, how it works, discussing fear avoidance, and if they are avoiding movement, that their pain is going to become more elevated because the receptors get more sensitive. And then introducing them to just low intensity exercise, so they're realizing that all those exercises aren't hurting them, but eventually are going to help them get back to more and more active activities. Okay. So if therapy does not work, then Dr. Abbasi is next going to talk about the next step.
So this is a fact that we have level 1 evidence that physical therapy and what many of you guys do is working. There's only very little level 2, mostly level 3 and 4 evidence for everything I do works. Meaning that as a physical therapist, chiropractor, family practitioner, you help more people, but statistically certain number of those people are not going to respond to everything you described, Lindsay. That is where my expertise comes in. And those numbers of the people that you cannot help is increasing because they are aging. We are getting older, and eventually all those mechanisms have their limits. Now, the number of the spine surgeries in the United States is actually, this older statistic is about 1 million spine surgeries a year in the United States. You're dealing with a big deal kind of process. Half of them are fusion, and I'm going to talk to you about minimal invasive spine surgery. In all other areas of the surgery, we have moved to a minimal invasive. In these authors talk about the general MIS. They say MIS is like antibiotic in surgery. We couldn't live without that these days. And they say, imagine you would keep the patient with a cholecystectomy 5 days, 7 days in the hospital. Our medical system would break down. Yet that is what we do for the spine. All societies actually are still in the infancy. They don't even think spine can go the minimal invasive pathways. This is from one of our major societies. And in other areas, they went to this minimal invasively because in most of the areas where minimal invasive is an everyday activity, you have exposure, you have an opening, and you have a cavity. Spine doesn't have a cavity and an opening, so it's hard for spine to get in the MIS endoscopic ways to the spine. Is really hard. So that's why they have not caught up. Now, these are muscles of the spine. Most of you are familiar with that. And a dirty secret of the spine surgeon is that when we open them up, we don't reattach them. We denervate them, we devascularize the bone because vascularization of the bone is through the muscles, and then we just let them be. When we come back 3 months later, it's all scarred. There's no muscle left there to work with. For you guys, if you do physical therapy, it's really very little multifidus or other muscle left there to work with. This is a picture that I want you to understand and take home. Take a mental picture of that spine. And this is a back, front, and these are the paraspinal muscle in the back, spine, the vertebral body, transverse process. Since 1950s, we go from the back, literally fillet patient open, and then get access to the spine. So PLIF is still performed. This is 70 years ago. And since 1980s, we are doing transforaminal lumbar interbody fusion, where we go a little more lateral, and the advantage is that we don't have to push a lot on the spinal cord. It is advantageous, but still a standard that is 40 years old. Since the 1970s, we know it's hugely advantageous to the patient if we don't destroy those muscles. So we start going from the front, but we have to go through abdominal organ, or go from the side, and then go maybe from the side and obliquely, OLIF anterior to psoas. But literally, people have died of these approaches because of vascular injury. Every day, every week or month, probably somebody gets a major vascular injury. Wouldn't that be great if we could avoid posterior and anterior element? Like, for example, through that really narrow band there. It's hard to do that, right? But that's exactly what we can do these days. Now, obviously, these approaches, we talked about that they have their own downsides, but if we could approach through that narrow band, that would be advantageous to the patient because we are avoiding posterior element and anterior element. And guess what? It is a hard thing to do, but our technology is finally there. We can do that. Now, this is open surgery. This is MIS surgery. All the muscles are detached from their origin. They are not reattached. And we do a lot of work to get there. And it's not about the skin incisions, but about what happened under the skin that makes this surgery minimal invasive versus this surgery. The time of the surgery is important. Can you imagine how much time you need to truly get there? The time of the surgery is an independent factor of morbidity, mortality, complication. Based on hundreds of thousands of surgery, they have compiled this that shows every 30 minutes in the surgery adds another 17% to the risk of the surgery. And I'm going to show you our result based on 1,000 patients and based on 8 published studies, and where we utilize that narrow path that I talked to you about through the Cambine triangle with 2 C-arms that make the surgery much safer, because at any point I know where my instruments are. We found out that this is for the first time a surgery that makes the surgery significantly shorter, not a little shorter, significantly shorter. Like surgery that could be 4 hours can be done under 1.5 hours, or even under 1 hour. Imagine all those half an hours that you are not adding to the surgery. This is one of our papers that we published. Not only we can show that our surgery is faster than open surgery or so-called MIS TLIF, but it keeps the safety margin with shorter surgery among higher BMI. Now, this is even with our initial paper study that we could show that patients stay in the hospital much, much shorter. our blood loss is 1/10 of the open surgery, and 96% of our patients actually ambulate within the first 24 hours. After open surgery, usually need 2 days before patient can independently ambulate. That's why they stay longer in the hospital. Now, I'm just going to just show you, and by the way, we could show in our first paper that is actually cheaper. Now, this saving adds to about $3 billion, our first study showed, to the US health economy. So, this is my conclusion. And if you are interested, come to our webpage. We are happy to give you more information regarding that and talk about the details of that. But it's definitely improved the patient and post-surgical outcomes because less damage is done. Enable faster patient recovery because they have to go through less surgical damage. Significantly reduce risk of the surgery. As a matter of fact, after 1,000 cases, we had only 2 superficial infection, whereas after open surgery, risk of infection is 3 to 5%. Our risk of surgery has been 0.27. And obviously provide effective treatment for patients who are on the borderline, and open surgery would be too devastating to them. So, in our study, we could show that they go back to even to heavy working like farming or ranching as well in significant shorter amount of time, even sometimes within weeks, which is after spine surgery unheard of. And obviously, our first paper could demonstrate that it's actually economically superior to any other kind of surgery. Now, this is how we do spine surgery still most of the time in 2019. And we finally found the right way to do that. So if you have need more information, catch up with me or with one of my team. We are happy. We have CME accredited events that we can invite you to, and they are online. I'm not going to stop right here, but this is just my last slide that I'm going to show you. This is was 6 months ago. These surgeries are the same surgeries. By modifying the technique, we go from 6 and 9 hours to under 1 hour. This is the reality. Get information. Just Google us. Find us, what we do. Because I think we are at the verge of totally changing the standard of care in the spine. And there is too much information, much more than I can give you within this 1 hour presentation. Thank you so much.